Good morning. I'm Colleen Florio, and I'd like to welcome you to this all-partner meeting of the AHI Performing Provider System. Before we get into the agenda, just a few housekeeping items. We have intentionally not planned any breaks for you before lunch or after lunch. So please feel free, if you need to step out of the room, make a call, as needed. We will be breaking for lunch at noon. We've provided a full hour for lunch, and you'll have plenty of time at that point, messages, networking, and so on, but certainly we understand if you need to step in and out of the room at other times during the day. Lunch will be a box lunch. It'll be available out in the hallway, and you're welcome to pick that up, head outside and enjoy the weather, come back into this room, and spend your lunch hour as you like. We will be circulating 2 microphones for people to ask questions during the event. Since we are recording the audio from today's event, we really ask that you use the microphones for the questions. If we don't use the mic, we won't be able to capture that question and answer. So those will be available. Also, you have index cards on your tables. So index cards are, if you have a question, there's not a mic near you, you want to write it down, make sure you don't forget it. If we don't get to your question, if we run out of time, please do use those index cards to write down any questions. We'll be sure to respond to those, and individually, if you put your contact information there, and/or compile them and make them available after the event. So I think that's it for the housekeeping items. Wow, looking around the room today, I see lots of familiar faces and a few new ones as well. And again, I'm Colleen Florio, and I have the pleasure of welcoming you on behalf of everyone at AHI to today's event. The meeting participants in the room today span the entire continuum of the healthcare system in the North Country. We have public health, home health, preventive services, primary care, hospital-based, long-term, and post-acute settings all represented today across the 9 counties that we serve, including a total population of approximately 700,000 people. As a group, it is your organizations that are the performing provider system. AHI was the catalyst for the formation of this PPS that has since been attributed over 140,000 individuals. That number includes Medicaid beneficiaries and the uninsured. The efforts that we undertake together are designed to improve the overall quality of care and health of this population, but in fact will impact that 700,000 as a whole, regardless of payer. Today, we are making a pivotal shift from planning to implementation. And I want to start the day by thanking you, by thanking everyone for your active participation over the past year, for your time, your expertise, and your patience and perseverance in these times of rapid change in healthcare. From our collective view inside of New York's healthcare system, it's really easy to lose sight of the sheer magnitude of the historic reform efforts that are underway in our state. The change has become commonplace to us, and yet it is uncommon nationally. New York is at the forefront of healthcare innovation and reform, and has become a magnet for policymakers, researchers, consultants, and of course vendors from across the country and internationally. And AHI is very proud to have been the catalyst for the establishment of this PPS that's well positioned to be a leader in population health innovation throughout New York's North Country. Many of you present today have worked with AHI long before DSRIP. A core group of you have been intimately involved in all the details of DSRIP. Others maybe heard about projects early on, were part of some teams, and really aren't aware of what's happened since. So we welcome all of you today. We've tried to craft an agenda that can briefly reorient all of us, as well as provide new information and next steps for the entire group. So we hope we have a little bit of something for everybody. We'll spend some time in the forest and some in the trees. And with that, I would like to move on to tell you just a little more about who we are. So briefly, AHI is a joint venture of Adirondack Health, Glens Falls Hospital, Hudson Headwaters Health Network, and UVM Health Network, Champlain Valley Physicians Hospital. Kathy Humke, of course, is our CEO. Kathy, raise your hand. The Health Systems Transformation Senior Management Team includes myself, Bob Cawley, Director of Health System Transformation. Bob, you waved your crown. And Rachel Hajos, Director of Health Systems Development. Rachel, give them all, there we go. Lottie Jameson is our Vice President of Regional Planning and Development. She's here in the front. And she and Megan Murphy, Megan is right by her side. Megan is Director of Community Health Services, lead the community, Regional Planning and Community Health Services arena. But all of our programs are designed to work together to improve care, lower cost, and realize a healthier future. I still get asked sometimes, tell me again what AHI is? So we're an organization that works to accomplish our goals in 3 ways. We promote population health best practices and implementation strategies. We manage programs for health advancement, and we work to ensure that individuals have access to care. So AHI is frequently the catalyst for new endeavors. We identify opportunities, such as this DSRIP opportunity. We convene stakeholders. We facilitate collaborative planning processes. And of course, we spend a great deal of time working to secure the funding that's necessary for these initiatives. So our history goes back to 1987 with the formation of the Adirondack Rural Health Network, which became a program of the Upper Hudson Primary Care Consortium. The consortium established in 2004, at that time its sole member was Hudson Headwaters Health Network. In 2010, with the establishment of the Adirondack Medical Home Pilot, now the Medical Home Initiative, the availability of HEAL 10 funding and the multi-payer advanced primary care practice program, at that point, primary care providers and hospitals, our member organizations, came together. They identified the need for an organization to provide central services, and the consortium was reorganized to be a 3-member organization and was renamed the Adirondack Health Institute. Since that time, a 4th member, Glens Falls Hospital, has joined AHI. Subsequent to the establishment of AHI in 2011, we've been fortunate to have received funding from the New York State Health Foundation, and we worked to help establish the Adirondacks ACO, an independent organization that participates in the Medicare Shared Savings Program. More recently, AHI is helping individuals access coverage through our EASE department in the New York State of Health. And of course, the reason we are here today, we look at 2014, we see the Performing Provider System, the DSRIP initiative. Even more recently than DSRIP, AHI has been awarded Population Health Improvement Program, or FIP funding. We are currently working in 9 counties with all payers. You'll notice when you look at our service area that there are fewer dots in St. Lawrence and Fulton. Those are areas where AHI has only recently expanded. And you'll see slightly fewer dots also in Saratoga County, where our work has really been more in the northern reaches of that county, where residents tend to access care to the north. So that's really a utilization pattern where persons who tend to access care at Glens Falls Hospital or one of Glens Falls Hospital or Hudson Headwaters Health Centers in northern Saratoga and southern Warren County. So that's who we are and where we work. And at this point, I would like to turn it over to Kathy Humke, our CEO. She will pick up on the population health theme and explain to you the development and current status of the AHI PPS governance.
Thank you, Colleen. I'm wired for sound. Great, thanks so much. And welcome. So in order to create a shared governance model across the care continuum, we needed a shared vision. And early on, through our PAC, our project advisory committees, through our interim steering committee, also adopted by our board of directors, we came to the conclusion that the North Country Redesign Commission vision for the region, which was to ensure New Yorkers in North Country achieve high quality, better health outcomes, and lower costs both now and into the future, was an appropriate vision. It was Commissioner Shaw brought together a commission back in 2014, and they, 2013, is that what it seems like a blur, frankly. And they adopted this. This was the vision that came out of that. And that commission represented not only our region, but our regions to the west, including Jefferson County. So in order to achieve this shared vision, integrating the core competencies of the DSRIP PPS and the Adirondack ACO will ultimately help the region achieve its population health management and evolve an integrated delivery system and value-based payment goals. So to effectively develop the PPS governance model, it began with the Department of Health mandated establishment of a project advisory committee, which was followed by the establishment of a formal governance by September 30th of this year, our #1 milestone, our first milestone. So we worked with legal experts to determine the models that would be acceptable under New York's DSRIP programs. Sample governing models and charters were obtained, revised to fit our needs. And the AHI PPS Steering Committee reviewed the structure and charters and endorsed them in September. The AHI PPS Steering Committee is the body that received regular updates on the models and provided feedback during the development phase. AHI as the lead entity is a fiduciary, and as such, AHI is responsible for collecting DSRIP funds from New York State Department of Health, distributing these funds to participants, and monitoring use. Additional responsibilities include overseeing the implementation of each of the projects, the governance process, developing an IT strategy of the PPS, and overseeing implementation of that strategy, and as needed, entering into scopes of work with certain participants that set forth additional rights and responsibilities of those participants, including for participants who receive DSRIP funds. When it comes to the role of these participants, Colleen's going to speak to that later this afternoon. AHI itself was reconfigured during the month of August to better meet the needs of the PPS. Four more member organizations came together and determined that we could reconfigure our board of directors across the care continuum. Our board representation by county is inclusive, and our board representation by sector includes providers, education, hospital, post-acute, public health, our business community, consumers, as well as behavioral health. Our governance structure is a collaborative contracting model. For many of you sitting in the room, we initially looked at a delegated model during which we were going to propose the formation of a new company. And since that time, it was determined through some of the governance guidance that came down from Department of Health that we would form a model that AHI will enter into the DSRIP participation agreement, which each participant in the AHI PPS that will assist with governing the operations. We look to our partners, their knowledge and skills, which includes strategic planning, finance, data analytics, clinical integration, provider relations and engagement, health information technology, clinical quality and operations expertise. Many of you that are attending this meeting, I see, have participated in PAC, are participants in the interim steering committee and many work groups, and we do encourage you to reach out if you are interested in continuing to work with our team to build this model. So in order to effectively operate, we have developed a charter outline that our committee structure underneath DSRIP. I'm going to go back to that just a second. We have a finance committee, clinical governance and quality committee, IT and data sharing committee, workforce, community and beneficiary engagement committee, and network committee that will be populated. We are also looking at a shared governance model with the Adirondack ACO. So included in these charters will be certainly composition, list of members, and we will be adhering to a consensus-based process for decision-making that facilitates our participant and community stakeholder engagement. Our steering committee appointed by the Adirondack Health Institute, it's going to consist of 20 and 30 representatives, including at least one AHI board representative. The steering committee will consist of 20 to 25 members, including the remaining members will be selected from among the PPS partners, and the chair will be appointed by a majority vote of the members of the steering committee. The members of the steering committee will serve for 1-year term. Any midterm vacancies in the steering committee will be filled by AHI, and the individual appointed will serve the remainder of the term. The members of the steering committee may be removed for cause by AHI or upon vote of 75% of the members of the steering committee. Cause shall include failure to attend 3 consecutive meetings unless absence is excused for good cause, and the termination of a steering committee member's affiliation with a PPS participant will trigger for the steering committee to re-examine whether the individual may keep their membership. The steering committee will make a recommendation to the AHI CEO, who will make this determination. So as we look at the responsibilities per the charter, certainly leadership and oversight of the DSRIP program, including overseeing the governance structure of the PPS, overseeing the implementation of DSRIP project plans, including ensuring that decisions are made in a timely manner and implementation remains on track. Monitoring DSRIP milestones and metrics, they'll review the actions and decisions of the Finance Committee, the Clinical Governance and Quality Committee, the IT and Data Sharing Committee, the Workforce Committee, the Community and Beneficiary Engagement Committee, and the Network, and any other committees that are established for the PPS collectively. We are very pleased that our steering committee's interim steering committee continues to participate. As you can see, there's a lot of responsibility, and we look forward, the AHI board looks forward to working collectively with them. There's other committees through appointment, which will include a finance committee, responsibilities of making recommendations with respect to allocation and distribution of the funds, certainly subject approval to the steering committee. We'll have a clinical governance and quality committee, and that's one of the governance models that we look to share with the Adirondacks ACO, certainly as they perform the Medicare Shared Savings Program, and as well as we have the medical home and we have the health home. So there'll be some collective development of clinical protocols and procedures. We have an IT and data sharing committee appointed by the steering committee, and they're going to be focused on developing an IT strategy for the PPS, subject to the approval. Our workforce committee, again, is going to be appointed by the steering committee, and they'll be developing a workforce strategy for the PPS and develop a workforce recruiting and retraining program as well. Community Beneficiary and Engagement Committee, another governance committee that we will share with the Adirondacks ACO, and will include developing a community engagement strategy for our PPS and developing a cultural competence and health literacy strategy for the PPS as well. Network Committee is going to be monitoring the network of our participants to ensure that it's adequate to support the implementation of the projects, and also make recommendations to the steering committee regarding improvements and changes to the PPS network. So our next steps. In October, our steering committee is surveyed for representation by sector, geography, and knowledge. We will be working closely to nominate a chair. We're working with them to nominate the chair. Also, our subcommittees are being convened to review the charters and compositions, and also make recommendations for expanding and revising committee membership. And as I stated, if anyone's interested in participating in any of these committees, please let one of Colleen or Rachel know. Also, the AHI PPS Steering Committee's recommendations will be taken to our newly reconfigured Board of Directors. We anticipate our first meeting in November of 2015. So as we look at our performing provider system, it's not only governance, which sets priorities and policies and evaluates the performance of the organization as a whole, it's management. It's management that's going to carry out the functions, set the procedures, and implement the process, as well as evaluate performance of the parts of the organization against the targets that have been set by the Department of Health.